What you're about to hear is nothing more than revolutionary in the concept of how we should deal with men and their prostate glands. It's critical that the listening audience understand that early diagnosis with regard to prostate cancer may be counterproductive, and that you must be thoughtful about how you're going to interpret the info. My goal is to give men options. And the option we propose is that you take your PSA, you get perhaps an MRI of the prostate. There are studies that can be done to discern if the cancer, if it's present, has actually left the gland. So there's total body imaging that can be done. You don't need a biopsy to get this information. There's no information that will come from that biopsy, in my opinion, that has value. Because remember, we've already established based on the studies that removing the gland doesn't help, that radiation doesn't help survival. So why would you put a needle in? Prostate cancer should stay in the gland.
Hey everyone, it's Tamara Thompson with Broadcast Your Authority. I'm super excited for our next guest, and I'm going to have my co-host Corey introduce. Go ahead, Corey.
Sounds good. So Dr. Petteruti is a practicing physician dedicated to enhancing human vitality by addressing health at a cellular level. By integrating conventional medicine with advancements in cellular biology, he develops innovative approaches to combat aging and restore optimal health. With 30 years in family medicine, Dr. Petteruti has gained deep insight into patients' greatest concerns and unmet needs. Through clinical observation and outcome-based research, he continually refines treatment strategies to deliver effective evidence-based care. Driven by intellectual curiosity, he is committed to pioneering solutions for complex health challenges. Together, he and his wife / business partner / co-founder, Shannon, together run Intellectual Medicine. Welcome to the show. To start off, I would love to hear what is intellectual medicine? How did it come to be? And we'll go from there.
Yeah, well, thanks everybody. Intellectual medicine is the evolution of my own thought process and clinical experience. It is thinking about what we do instead of just doing.
Oh, I like that.
So in medicine, we have standards of care. They're not bad. We have consensus. Consensus really becomes where you go when you're tired of thinking about something with partial knowledge. So we're going to develop a consensus. It's not bad, but it suspends thought to a degree. So I looked at my patients and I looked at the outcomes I was getting, and I was not satisfied. I entered this business to have life-changing impact. And that's where I came up with intellectual medicine. Let's think through this. Let's step out of a paradigm of consensus and break it down. What can we do better? And that became the genesis of intellectual medicine, the name, the origin of it as an endeavor. It came from me being unhappy with my job. I come home from work every day and I'm just not happy. And Shannon goes, you got to quit your job. I said, okay, that's dumb. I'm going to quit being a doc. I'm going to quit my job. She goes, yeah, man, you can't do this anymore. What she meant was conventional standard fee-for-service medicine. It had become so intellectually constraining that as my personal knowledge expanded into spaces, cellular-based healthcare, all disease and all health starts at a cellular level. We're waiting to see something catastrophic and then trying to get at the tail end of it. So anyhow, I'm not happy, coming home miserable. Shannon says, you got to quit. I said, okay, let's see. Let's do the math, right? We got a mortgage. We got 2 kids in college. We got expenses. You want me to quit this job? She goes, yeah, it'll be fine. It'll be fine. Okay. She has steel nerves.
Supported you in this.
So I listened to her. I quit my job. We surrendered all insurances. I have nothing against health insurance per se, but when they impose upon freedom of thought, I remember a time when, and my father was a family doc, and when I started my practice a million years ago, we had a lot more latitude. We could impose, we could direct, we could think. The computer really has crushed freedom of physician's thought. Y'all have been to your doc, right? What happens? They stare at the screen. Click, 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 click.
Yep.
I got to fill in the boxes. I've got to, did you beat your wife this week? Did you use your seatbelt? Important issues, right? But they jam up the time.
Right.
Where's the real work happening? Why did this occur? Well, so I think it occurred in part because, we allowed it to. So I had that choice, right? Comfort and income, or break away and try something intellectual medicine very different. Well, what do I have to lose? Go broke? Okay, I've been that before. They don't have debtors' prisons. That's cool. I'm going to die someday. I'll sit there going, damn, I should have. So anyhow, that's how we jumped into it. It was really to Shannon's credit because she had unblinking confidence.
We were talking before this, we were talking about unconventional, and you were just saying unconventional medicine as well. And we were talking about like prostate cancer in particular. And so like early detection, treatment, life after diagnosis, you were giving some different takes on it. So like early detection, what are your kind of thoughts on that?
So I'm really grateful for this platform. What you're about to hear is nothing more than revolutionary in the concept of how we should deal with men and their prostate glands. I share with you that everything we've been doing based upon instinct, based upon rational thinking, and it has all had no benefit. We have hurt men. We've sacrificed their health and their manhood. So my premise, not my premise, but the research will back what I'm about to say. In fact, I'll give you a snippet historically, because it's important. This is where I was, right? Looking at my patients, getting prostates removed, getting radiation therapy. As a humble family doctor, when a patient is diagnosed with cancer, we sometimes take a back step. Well, go to the oncologist. They're wonderful people, good-hearted. But we should never abandon our focus on the patient's health, vitality, cellular level. Cancer or no cancer, right? You have a right to live with abundant vitality. And right, whose body is it? Who makes the choices? My experience with oncology has been one of commandeering direction. You have to, this is what you're going to do. But time out, doc, where's the risk benefit? What's the data? So I went back and looked at the data. You know what I found in archaeological studies? They look at, of course, bones and such. They found evidence of metastatic prostate cancer. When you look at archaeological evidence, however, the rate of cancer documented is around 1%. 1%. Now, obviously, it's limited. Don't look at bone, but it begs the question: is cancer a modern disease? Are we doing this to ourselves? Now we're in the 1800s, and the first documented prostatectomy in modern times was done in England. And at the time, the surgeon who removed the prostate gland said, "This is a really rare disease. You're not going to find very often." How do we get from that to where we are now, which explosive rates of prostate cancer? Well, a lot of it has to do with the invention of the PSA test in the 1990s. So in the 1990s, the prostate-specific antigen test came on the scene. Prior to that, how in the world did we diagnose prostate cancer? Digital rectal exam, abnormalities in urinary flow. In the 1940s and 50s, by the 1950s, prostatectomy became the standard of care, removing the prostate gland. Right? After all, you take the gland out, you can't die from prostate cancer because the gland is now gone. From 1950 to 1960 to 1970 to 2000, despite this standard of care, the death rate from prostate cancer kept going up. So right away, my curious mind is wondering, what's going on? How did we fail? One of the problems, if you will, with treating prostate cancer is the fact that it almost never kills people. Now, I understand it is a leading cause of cancer death among men. However, the actual death rate is dramatically low. The 5-year mortality rate from prostate cancer is almost 0%, almost, which means that I could tell you, I'll clip your toenails, it'll cure you, is going to have a good outcome. Now, I'm not implying that that's actually what occurs. What occurs really is logical progression without evidence of benefit. I take out the gland, I cured you. I heartily object to that phrase. No patient should ever be told in the diagnosis of prostate cancer they are cured. Never. It's a cellular disease. We got it all, say the doctors. No, you didn't. It escapes on a cellular level. That's why they give you chemo afterwards. That's why they give you radiation. Because intellectually they acknowledge that, right? So back to the problem at hand. Now we're in an era where a PSA test happens. We already established removing the gland didn't correlate with benefit, at least statistically when we look societal-wise. Now we have a PSA. Your PSA should be, these are air quotes, right? 4.0 or less. Arbitrary number. Remember, the test came after we started treating prostate cancer. So now we've got a paradigm, a standard of care, a consensus that taking out the gland's the way to go. But suppose you don't want that. How about radiation? Non-invasive. Isn't that better? Remember the seeds? Maybe not. Put radiation seeds in the prostate. One of the most important moments when I was reflecting upon this came when I read 2 studies. I'll share them with you briefly. One is the Pivot trial, was published in 2017. They observed men with prostate cancer. Half the group had the gland removed. The other half did nothing. They followed them 15 years later, and they found no difference in death rate. And they found no difference in the death rate from prostate cancer. How could it be that you have your gland removed and you die from prostate cancer? Remember, cellular escape. Well, that's compelling. 2017. 2023, April, New England Journal of Medicine. Protect-T trial was published. It took them nearly 20 years to gather the data. Now note the lag time, 20 years.
Right.
Again, they had roughly 80,000 men screened. Of those, roughly 1,500 entered the study. 3 groups of 500. One group had the gland removed. The other group did nothing. And the third group had radiation. Then they followed them. And they found that 15 years later, they all had the same death rate.
Wow.
And they had the same death rate from prostate cancer.
Wow.
Wow.
Here we have a treatment guaranteed to cause harm, surgical harm. It ain't pretty.
Mm-hmm.
Here we have a treatment that is high probability of adverse effect. We're going to take out your prostate gland. You might pee on your shoes and you may not get an erection, but by golly, we're going to cure your cancer.
We have to do it.
Right?
Yeah.
I'll tell you, you're going to chop
Yeah.
on my
You might have
manhood.
to.
I want a golden boss ticket. And if I ever get prostate cancer again, you, Mr. Urologist, write me a check for $1 million.
Yep.
Yeah,
You
exactly.
want to go surgery now? Huh? You like that deal? So we have the null effect. We have guaranteed harm. What about radiation? The worst yet,
Mm-hmm.
because now you've got delayed negative consequence.
Right.
5-10 years later, you get radiation proctitis.
Mm.
You're leaking stool, nothing to be done. Radiation cystitis, can't control your bladder. So these are the problems. And men are not given really an alternative. So we've developed one, intellectual medicine. Think through the problem. And then I have the wonderful privilege of treating patients, right?
Mm-hmm.
So I get to actually put into force that which I contemplate in consultation with the patients.
I'm curious. So we're
Yeah.
talking about more about the treatments and things of going on in these advancements, but like when they come to you on that side, though, what are truly the warning signs that they have to actually get the knowledge to be able to come to you first? Like, what are the actual warning signs?
Well, the PSA being elevated is a driving force, right?
Okay.
'Cause most men,
Makes
as you
sense.
age, you have some issues with urinary flow. That's common.
Makes sense.
They go to the doctor. The PSA in 2012, they eliminated it as a screening study.
Is that
They put it back in 2018. They don't know what to do with it.
is that the only like warning sign primarily, or is there other things that people come to and say like, hey, I'm
Right.
experiencing this, and it may lead to that being the reason?
Well, it's critical that the listening audience understand that early diagnosis with regard to prostate cancer may be counterproductive,
Mm.
and that you must be thoughtful about how you're going to interpret the info.
Mhm.
So
Got it.
yes, if you have blood in your urine, go see the doctor. If you can't pee, go see the doctor. If your PSA is elevated, listen to my podcast and check my website and go
Yeah.
see the doctor, because it's fair
Mhm.
to choose your path.
Yeah.
So the number one reason why people may enter is because of an elevated PSA, and because I now have the freedom to engage. People know when they come to see me, they're not going to get just a standard of care answer.
Yeah.
Now they're seeking me out because they want an alternative. And we put the principles in action.
Mm.
Yeah, I love that. I mean, we were talking earlier. I mean, I mentioned I spend like the most amount of money I spend every month beyond my actual bills is on preventative health. All kinds of different, vitamin supplementation and trainings and facilities, cool protocols, and I love it. I actually enjoy it. So it's not like I feel forced to do it. I don't have any currently any health things or anything I haven't in the past. I just enjoy it. The big reason for me though, and just to double down on your point, and I wanted to bring up a question at the end of it is, I've had one of my best friends go through testicular cancer and then and do the standard of care. I've also had a family member go through breast cancer, and both times I went through all of their appointments, and the doctors do like kind of this, and this is no offense to anyone who's gotten standard of care and it worked for them, no offense, but there was like kind of this timeshare salesman thing where you got like one guy come in and then you have like a closer come in afterwards and they give you 5 minutes to think about it, or you got to sign on the line. And
They're
I'm
just
like,
supplying information.
they are, but it was just this whole, so it was just
Seem
a
like
weird,
they care.
yeah, it was a weird thing. And it's, you read through it, you have to sign that you're guaranteed to get a secondary cancer if you go through the treatments. As far as at least for both of them, testicular cancer and breast cancer, there's guaranteed secondary treatments if you get, or secondary cancer once you go through chemo. So for the breast cancer person in my life, I opted for them not to because the standard of care would have killed them. They're like 112 pounds, can't really gain weight. They don't have the capacity to actually go through a lot of those treatments. Not to say it doesn't work for everybody.
Mm-hmm.
The best friend that I had went through the treatments. It's fine. It's good to go. But what you were mentioning and why I wanted to give that backstory is there's a holistic health of you as a human being. There's all these different factors. There's nutrition. There's all kinds of different things. And not to just jump to early warning signs and say, okay, well, the doctor said I have this, drop everything. Let's just focus on this treatment. What are some of those things? And I don't know if it's specific to maybe prostate, other things. What are some of the things as a holistic thing for preventative health that we should all be thinking about to not necessarily prevent any disease, but give us the best fighting chance?
Right.
To stay healthy.
Absolutely. Absolutely to prevent them, right?
Yeah.
Nobody wants to die from cancer, heart disease, or dementia. We want to die healthy. Now, that seems paradoxical. You want to die healthy, well beyond 100,
right?
After you had a head cold.
And in your
like, hey, what happened to Steve? Where's he? Yeah, no, man, he got sniffles. He died last night.
Yeah.
I just saw him last week. He was playing golf. I don't play golf, but I could.
Yeah.
It's weird to think about how we want to die, but that's how I want to die. So what can you do preventatively? Well, each of these cancers are unique and different. So that's to be emphasized. And there are some standard of care therapies that are compellingly valuable. So you want to be thoughtful about discriminating should you be confronted with a disease. But you ask an important question. Remember, cancer is a cellular disease. What we believe to be early diagnosis is not. It takes cancer about 7, maybe 9 years to get to 1 centimeter diameter, something called doubling time. You go from 1 cell to 2 to 4, et cetera. It takes 30 doubling times for any cancer to get to be 1 centimeter in size, any tumor, right? 30. You get to 40, you're dead. So by the time you see that 1 centimeter tumor, you're 3/4 of the way home. So your point's well made. We all get cancer cells every day. Our philosophy, the intellectual medicine approach, is to acknowledge that and make the body inhospitable for manifestation of tumors. See, there's a difference between a cancer cell and tumor. Think a soldier scrambling around in the front versus one in a fort. I want to kill cancer when it's scattered around. I want to kill it when I don't know I've got it. When there are no early warning signs other than what's the number one risk factor for having breast cancer? Answer, being a woman with breast. What's the number one risk factor for any form of cancer? Answer, age. Genetics, relatively minor. So we're all at risk. What can you do? You're already doing it. Stay lean, eat intelligently. There are no such thing as a superfood. Can I put that in bold print? The superfood is
You heard it here first.
But my acai bowl,
Yeah, I heard it here
my
first.
acai bowl
Less.
in my.
That's the
I don't
headline.
care how many blueberries you eat, right? Too many will harm you. So percent body fat, there are 14 different types of cancers associated with excess adiposity. We have an explosion of the obesity epidemic, another conversation, but it's not their fault. Right? So percent body fat reduction, avoidance of toxins, heavy metal, right? Critical. We talked about that before, but being able to discern the amount in your body. Vitamin D correlates in our world meaning high dose vitamin D, managed by your provider. You got to check blood levels, can also be resilient. Some cancers are totally worth screening, like skin cancer. But how about prostate cancer? One of the messages I have as a young man is to be mindful of percent body fat. And when you get your PSA tested, do not, never, this point of emphasis, right? Another bold print. Do not let anybody put a needle in your prostate gland ever. There's no reason for it. There's no information that will come from that biopsy, in my opinion, that has value. Because remember, we've already established based on the studies that removing the gland doesn't help. We've already established based on the studies that radiation doesn't help survival. So why would you put a needle in? Prostate cancer should stay in the gland. Cadaveric studies of men over 90, over half of them had prostate cancer cells in the gland. What that tells me is that's a normal process. I want someday to develop prostate cancer cells. I want to not know that they're there. I want to die with them in me. And if my PSA goes from 2 to 12, nobody stick a needle in me, because you can disrupt cancer. If you stick a needle in it, you can pierce the seal. Now, that's a controversial statement, and I stand by it, because there are studies validating the dissemination of cancer via needle sticks, both in breast cancer world and otherwise. I'll tell you what's logical. If you're worried you may have prostate cancer, your PSA is elevated, get the gland removed. That seems extreme, right? But at least you're not piercing the seal. There are, however, my goal is to give men options. And the option we propose is that you take your PSA, you get perhaps an MRI of the prostate. Let's look at the anatomy of concern. There are studies that can be done to discern if the cancer, if it's present, has actually left the gland. So there's total body imaging that can be done. You don't need a biopsy to get this information. Then, so I've got patients in my practice, their PSAs are hovering around 15. That's a level at which standard of care is to get a biopsy. They don't want anybody to stick a needle in them. Oh, by the way, some of these men are on testosterone, but isn't that pouring gas on a fire? Well, maybe not. There's new information looking at the correlation. We now know that men with low testosterone levels have a higher incidence of prostate cancer. How about men on testosterone? I have a gentleman in the practice been on testosterone since 2012. In 2018, he had an abnormal MRI of his prostate showing a high probability of prostate cancer being present, 2018. He said, I do not want to stop testosterone. Its value to me is that great. I said, okay, here's what we're going to do. We're going to give you the supplements. We're going to give you repurposed drugs. These are prescription agents that have been shown to have anti-cancer properties, safe, generic, when properly managed. And we're going to monitor 2018, 2020, 2023, no change in the MRI while on testosterone.
Wow.
Proof? No. Evidence? Yes. This is absolutely compelling. I call him the Baron. I have permission to use that because he's already been on my show. The Baron in his 50s was diagnosed with prostate cancer via biopsy in the old days, right? They didn't have any other information. Doc says, okay, you got prostate cancer. I'm going to set you up for surgery to take your gland. The Baron says, no, you're not. Doc says, what are you talking about? He goes, you're not taking my gland out. He says, that's suicide. You're going to die. He says, oh, maybe. Should I take my gland out? At the time, he had a 30-year-old girlfriend. He said, you're not screwing with this. So the doc was really upset. The Baron goes on. Now the Baron's my patient. He's been with me for many years, and he never went down the pathway of any conventional treatment. He still has his prostate. He still has prostate cancer. He still has a young girlfriend. He's now 81.
Wow. Wow.
81. The doctor has since died, but so it's, didn't wish any ill to him. However, think about the doctor's expression. That's suicidal.
Yeah.
That was inaccurate. There was no evidence to support what he had said.
Mm-hmm.
Yeah.
Nevertheless, here's the Baron. He's 81. PSA, I told you, if it was above 4, it's problematic. His PSA at one point was 80. And he went to his consulting doc, and the doctor said, well, you know what they do to guys? This is horrible. First, they whack your gland, then they irradiate you. And when that doesn't work and the PSA starts to elevate, you know what they do next? They castrate you.
Wow.
They castrate you. Now, in the old days, we literally used to cut men's gonads off. Now, it sounds much more elegant. Androgen deprivation therapy, i.e. chemical castration. Yikes. What happens next? The brain gets dull. You grow man boobs. You get fat in the midsection. Your sex drive goes away. You get depressed. You get hot flashes. And the prostate cancer will advance anyhow.
Wow.
That's insane.
100%. So what are we doing?
Yeah.
Can we do better? So now the Baron was told to go on androgen deprivation therapy. He once again reneged. 81. His PSA is now 125. We did imaging studies to see if it had left the gland. It had not. It's hard for men. It's hard for doctors. It's hard for people when the PSA test doesn't correlate the way we wish it would, when the outcomes can be independent of it, and when the treatment options are so awful, and yet we're not given an alternative. So at Intellectual Medicine, our hope is that we can educate people, promote what we have discovered in the literature, in the history, and frame it out differently. Repurposed drug therapy, detoxification of heavy metals, the use of non-toxic interventions so we can monitor and support. So a man doesn't have to face this dilemma.
Love
You can
this.
either irradiate, surgerize, or do nothing. Yikes. So the Baron, we look at my other man with his testosterone. These would just be case studies, but for the background of info.
Mhm.
Is it wrong to get the gland out? No. At the end of each day, we sleep in our own bed, making peace with our own decisions.
Mhm.
There are some people, given a diagnosis of prostate cancer or the likelihood it's there, they can't sleep. Taking out the gland has collateral benefit.
Right.
Mm.
Mhm.
So my goal isn't to say, hey, they're idiots, do my thing.
Right.
My goal is to say, pause, think, consider. You can't make a bad decision. You cannot, because it's yours.
This
Love
is
that.
fascinating because I feel like just before I was mentioning, I have, an uncle and my father both have been diagnosed with prostate cancer. And so in the back of my mind, there's always been this low grade fear and sense that this is probably my fate as well. And now I'm hearing you say like this gives me a lot of hope, or a sense of, you also mentioned it's not really hereditary in the way that we might think that it is. So I think that's a whole other conversation. But I think there's also a sense of what I'm hearing you say is that there are options beyond those treatment protocols that, are maybe more traditional. So I feel like I've at least got a resource to someone I can call, when and if that day comes, and feel like it's not maybe the boogeyman that I thought it was.
Well, you're going to start right now, like Corey was saying, right?
Right,
The
right.
cellular support,
Mhm.
all the healthy things we're doing. My wife once asked me, if you knew you were dying, would you regret anything?
Mm.
She's in reference to what I do. I, like Corey, I'm on hormone therapy. I do IV infusions every month.
Mhm.
I'm on
Mhm.
sirolimus, a whole nother repurposed drug, right?
Yeah.
Mhm.
No, I'd be okay. Like I practice anti-aging life extension medicine.
Yeah.
Yeah,
It's
so-
not immortality medicine.
Right.
That idiot that wants to not die, yeah, good luck with that.
Yeah.
The rest of us just want to die young at an
Yeah.
advanced age.
Yeah, be healthy a little bit longer.
Yeah,
That's
absolutely.
it. That's it.
And really avoid the things in conventional medicine that are toxic, harmful, and not really proven of merit. And
Mm.
you know,
Mhm.
Mhm.
back off patients, give them a chance. Let them
Yeah.
make decisions.
Yeah.
Well, I appreciate you joining us today and sharing a little bit more. But you also have a podcast, which is also the same name as your company as well, Intellectual Medicine.
We do.
Where else can individuals find you, connect with you? What would be the best way to
Well,
reach out?
thanks. Probably the best way is going to Intellectual Medicine, our website. From that base, you can find the podcast. We have information about all the things I've discussed today, as well as a wide range of other supports and options on how you can incorporate anti-aging primary care into your life so you can live long, die young at advanced age, stay healthy. That's the game plan.
I love it. Thank you so
Love it.
much for joining us today. I really appreciate you
Welcome.
coming out.
Thanks.
Yeah,
So
amazing
good.
work.
Thanks, Steve.
And those of you watching the show, be sure to subscribe, ring that bell, follow Broadcast Your Authority everywhere. Leave us a review on Apple or Spotify. We appreciate your feedback, and we'll see you in the next episode.